Ευχαριστώ πάρα πολύ όλους τους ομιλητές της προηγούμενης τράπεζας που με τίμησαν με την παρουσία τους και τα πολύ ενθαρρυντικά τους λόγια. Τώρα θα περάσουμε στην επόμενη ενότητα σχετική με το αντικείμενο της οφθαλμικής ογκολογίας, στην οποία κάθε φορά θα παρουσιάζονται ένα ή περισσότερο οφθαλμοογκολογικά περιστατικά, που πιστεύω ότι θα ενδιαφέρουν πάρα πολύ και τον γενικό οφθαλμίατρο. Σήμερα έχουμε τη μεγάλη χαρά να έχουμε σήμερα στην ενότητα αυτή την consultant, διευθύντρια, οφθαλμική ογκολόγος του Moorfields Eye Hospital, την κυρία Quhill. So we are very pleased to have Ms. Quhill today in this session of Ocular Oncology Case Club, who is an ocular oncology consultant of Moorfields Eye Hospital. Hiba, it's a great honor having you here in this very first episode, and we are all looking forward to see what hides a second bite of the cherry.
Thank you so much for having me. I will share my slides now. Can you see my slides?
Of course. Of course.
Wonderful. Well, thank you so very much for the invitation. And it's a great honor to be here and present under the auspices of the Hellenic College of Ophthalmology. And thank you to all of the organizers and sponsors. So I've titled my presentation A Second Bite of the Cherry for reasons which I hope will become abundantly clear. So I will present a single case from our experience in Moorfields and talk about the working diagnoses as they evolved during the case presentation. There was an initial biopsy and then a second biopsy. And we'll discuss how we came to our decisions, looking at the literature, and also a discussion of a novel biopsy technique. So our presentation is that of a 70-year-old man who presented to his local eye hospital. He presented with only 2 or 3 days of a painful red right eye with chemosis, and he had reduced vision in that eye. His past medical history, you can see, included diabetes and hypertension, and he had a family history of bowel cancer. So his vision was reduced to 618, improving to pinhole 612. He had anterior chamber inflammation and an exudative inferior retinal detachment with a variably pigmented choroidal lesion visible within the area of detachment. The OCT showed it was a very flat and undulating lesion, and the team locally weren't sure what they were dealing with at first. They thought perhaps this could be an inflammatory lesion, given the fact that it was a red, painful eye, or somebody somewhere thought, could this be a uveal melanoma? So locally, before he was referred to our unit in Moorfields, he had screening blood tests, which were all within normal limits, including normal inflammatory markers. He also had a CT orbit with contrast. The radiology reported that there was intraocular hyperdense material, perhaps hemorrhage in the right eye. There were no enhancing lesions, but there was some periorbital inflammation. So this really muddied the picture. The bloods looked non-inflammatory, but the CT perhaps favored an inflammatory diagnosis. It was at this point that the patient was referred to Moorfields and I met him. So I met him approximately 2 weeks later, and the only treatment he had had was paracetamol and cold compresses over the eye to try and help with the pain and the inflammation. His vision had improved somewhat. His eye was no longer red, but he did have quite significant conjunctival chemosis. When we examined the fundus, we saw this irregular shaped lesion in the inferior temporal quadrant, which was variably pigmented and had some autofluorescence changes, as you can see. OCT through the lesion shown at the various levels showed it's an irregular, shallow lesion. The surface doesn't fit with the dome-shaped lesions we tend to see with things like uveal melanomas, and we had what we call in England, at least, a lumpy, bumpy appearance, which is something we see quite often in things like choroidal metastases. B-scan ultrasonography showed this multilobulated, shallow lesion, 2.1 millimeters in maximal thickness, but 17 millimeters in maximum base. And there was a hint on ultrasound Doppler that there might have been some slow flow within the lesion. So at this point, our differential diagnosis was fairly broad. This is quite an atypical presentation. Could this be a sclerotic or an inflammatory lesion that's masquerading as a mass? And there's numerous case reports in the literature supporting posterior scleritis and other inflammatory lesions mimicking choroidal tumors. Could this be a choroidal metastasis, given the OCT features, despite the fact that the patient had no primary cancer in his history? And again, there are multiple case reports in the literature and series showing that choroidal metastases can present with an inflammatory picture and mimic a uveitic component. And then finally, could this be a primary uveal melanoma all along? And again, there are multiple case reports in the literature showing that some uveal melanomas can present with a very inflammatory picture and almost resemble scleritis when they present initially. So what did we do? Well, given the fact that the screening investigations had been essentially unhelpful from the local unit, we decided to go with a trial of treatment. If this was an inflammatory lesion, you would hope that the mass would melt away with standard anti-inflammatory protocols, and he was treated with both topical and systemic steroids. If this wasn't an inflammatory lesion, then the inflammation would die down and may reveal a more typical looking lesion to help with the diagnosis. So that's what we did. We spoke to him 2 weeks later, and almost all of his clinical symptoms had resolved and the patient was feeling much better. But he was reviewed locally by the original eye hospital, and they said the lesion remained and they had ongoing concerns for malignancy. So we brought him back to Moorfields, and you can see the difference in the clinical imaging with a 3-month interval. This leading edge seemed to have crept along in the 3 months between the original review and this further review, and the lesion was also slightly thicker. This, therefore, was no longer fitting with an inflammatory picture. So we decided that this was no longer in our differential diagnosis. So could this perhaps have been a choroidal metastasis? In order to try and get to the bottom of the diagnosis for this case, we had a two-pronged approach. We asked the local eye hospital to support us and perform a systemic workup looking for a possible primary cancer elsewhere. We also referred the patient to the vitreoretinal service in Moorfields to perform a transvitreal biopsy. The systemic workup included a dermatological assessment, a PET-CT, and an MRI head and neck, and all of which came back negative. There was no sign of a primary cancer elsewhere. So that left us with the VR biopsy to help direct us. This is the histopathological specimen from our patient. It was a very small sample, and when you look at the slide, you can see these blue crystalline deposits. That's actually a stain used by our histopathology colleagues to try and locate very small specimens within the pot that we send. You can see multiple red blood cells, and hopefully you can see my pointer. You can see these very tiny fragments of clusters of atypical cells with hyperchromatic nuclei. These atypical cells were stained with immunohistochemistry markers, but unfortunately all came back negative. So these were not melanocytic in origin and also did not appear to be from a particular carcinoma, at least on the screens that we used. However, our local histopathologist is extremely experienced, and she had the feeling that the morphology of the atypical cells resembled small cell lung carcinoma. So she was more convinced that this may be a metastasis, although we didn't have a definitive tissue diagnosis. And of course, that systemic screening was all negative. So then what did we do? This is where we come to our fabled cherry and the second bite thereof. We opted to perform a transcleral biopsy using the Essen or Quhill forceps. This forceps is a relatively new instrument, and it was designed for use transvitreally by our VR colleagues using the ports that are used for a standard vitrectomy. And there are multiple case series describing the technique using it transvitreally. Professor Bertel D'Amato, I'm very lucky to call him one of my mentors. He's actually described a new technique of using it transclerally, and that was the option we took for this case. So I'd like to describe with surgical imaging what we did for our patient. This is a different patient, but we still performed the technique in the identical manner. So just like with all ocular oncology patients, we start by doing a peritomy and exposing the sclera over the presumed base of the tumor. And then we use transcleral transillumination to try and get the shadow of where the tumor is and indirect ophthalmoscopy. And we mark out the position of the tumor, which you can see in the purple ink here. We also try to mark the thickest point of the tumor, which is represented by this deeper purple mark. And that's our ideal site for the biopsy. We produce a partial thickness scleral flap, reminiscent of those produced in a trabeculectomy. And this is used to try and limit the amount of seeding of neoplastic cells if this is indeed a malignancy. This is a close-up of the flap, and you can see a full thickness incision made at the hinge of the flap to allow access to the choroid. Here is a still showing the use of the Quhill forceps. It has two spoon-shaped aspects at the end of the forceps. And the idea is that it will cut off a lozenge of tissue. So when inserted and closed, it will pinch off some malignancy, some tissue, and you can see it there being placed on card ready for insertion into formalin. And here's a close-up of the sample within the jaws of the forceps. We then repeat that biopsy and we try and orientate ourselves differently each time we go in for a piece of tissue so that we can try and sample as much of the lesion as possible. To close, we use cyanoacrylate glue, the idea being that if there are any malignant cells that have been released by the biopsy, they will be frozen within the glue and therefore not able to multiply. And we close the flap, leaving you with a completed sclera at the end. And then, of course, you would close the conjunctiva and return the patient back to normal. There are certain advantages of the transcleral Essen biopsy technique over a fine needle aspiration biopsy, which is the favoured biopsy technique by many of the ocular oncology services worldwide. The Essen forceps allows you to get larger samples with architecture intact because you're getting lozenges of tissue which are between 1 to 2 millimeters in length. There's also less chance of perforating the retina, and we had a relatively thin tumour because it's a blunt-tipped forceps and you can enter the choroid obliquely, so you're more shallow. I've also used this technique for lesions posterior to the equator, as in our case described in this presentation for you today. The lesion in our patient was almost within the macula, and it would have been difficult to get a needle there safely without risking perforating the retina. And then there's the thought that perhaps there's less chance of seeding because of the scleral flap and the tissue glue holding everything together and preventing multiplication of those cells. So this is the histopathology specimen from that Essen biopsy, from our second bite of the cherry. You can see that it's mostly made of fibroconnective tissue with scattered melanin. So this is definitely choroidal tissue, but it's infiltrated with these atypical cells with hyperchromatic nuclei. Immunohistochemistry showed that these atypical cells were convincingly positive for melan-A and HMB45, the melanocytic markers, which the original extremely scanty biopsy from the vitreoretinal surgeons did not show any positivity for. So this was a convincing case of malignant melanoma, and the patient was treated there as a malignant melanoma patient. He was given plaque brachytherapy a few months ago, and so far he's doing very well. So I wanted to just talk briefly about the other biopsy techniques that are available, and you've heard from the wonderful Carol Shields and Aaron Singh about some of the techniques they use in their units. The choroidal biopsy techniques vary between being transvitreal or transscleral, and there are pros and cons to each of those, and can be performed using needle, as has been discussed, the vitreous cutter, as in our first biopsy in this case, a so-called incisional or cutting biopsy, as Professor Singh described with his case of the schwannoma, or more latterly by the Essen, as I say, only recently described by Professor D'Amato. There are pros and cons for each, and some of those biopsy techniques are described well in the review that's listed at the bottom of this slide. But I do think that the Essen is much easier for these thin posterior lesions, has less crush artifact, and shows you the architecture, something that is only really preserved if you're doing an incisional large size biopsy, which has much higher complication rates. So in summary and conclusion, I presented an unusual uveal melanoma case that presented with a very inflammatory picture. The vast majority of uveal melanomas present with visual disturbance, and then approximately 30% present asymptomatically. A much, much lower proportion of melanomas present with an inflammatory picture, although it is described in the literature. I also showed you how we in the Ocular Oncology Service in Moorfields navigated the diagnostic uncertainty in this case, and then described the novel technique of using the Essen biopsy in a transscleral route. Thank you so much for listening and for this wonderful opportunity to present to you all.
Thank you so much, Hita, for your very, very interesting and educative cases. I've got a question for you. The last month since I have returned to Greece, I think I saw around 30 cases of of patients with ocular metastasis, and happened all of those cases they had positive systemic screening. But what happened in cases that of patients that we have ocular metastasis, but they have negative systemic screening? Do we have a number of those patients with ocular metastasis and negative systemic screening? Which is, according to you, the best way to proceed?
So thank you so much for that wonderful question. The wonderful Carol Shields and her team has produced 2 excellent reviews of choroidal metastases and looking at the origins of those metastases. And approximately 16 to 17% of those metastases have no known primary, and systemic screening is entirely negative. It's extremely difficult to know what to do when you have a patient that you're convinced is a choroidal metastasis, and yet all the systemic screening has come back negative. We have a very close relationship with our medical oncology teams, and they're usually best placed to try and find those occult malignancies. But I think we really come into play when all of their systemic screening fails. If we can get a tissue diagnosis from the eye, the immunohistochemistry can often lead to the primary, which may have already been auto-regressed by the patient's own immune system, for example. But once we have that tissue diagnosis, the medical oncologists then have a good idea of how to try and manage those patients for us. I think it's really hard, though. Sorry. I think it's really difficult if the diagnosis is more unclear, as in our case. We had an isolated solitary lesion. And of course, this could be a new primary or it could be a metastasis. If you've got multiple nodules in an eye, you know you're looking for a metastasis, or you're pretty certain you are. And I think then you're going to just keep chasing that tissue diagnosis, even if you have to do the ultimate biopsy, which of course would be an enucleation.
Mm-hmm. Thank you so much. I think also Prof. Sigi is with us in this section. Prof, would you like to ask us a question? Do you have any comment on this case?
So I think I know the case a little bit from before, and I just stepped out. So I think before you do a tissue biopsy for suspected metastasis, okay, that's pretty much the most common diagnostic biopsy. I think you can do a good imaging. You can do CT scan, chest, abdomen, pelvis, or a PET scan. And almost always you'll find something. Okay, you may miss something in the esophagus, you may miss something in colon, you may miss something in appendix, you may miss a small carcinoid. I get all that. But I think in vast majority of cases, if you did imaging, you'll find something and you kind of go from there. But if you don't find anything on imaging, and that includes CT scan, chest, abdomen, pelvis, or PET scan, then I think biopsy is reasonable. I wouldn't jump into the biopsy right away.
Thank you, Prof, for your comment. And thank you, Hiva, for this very interesting case. Hope to see you, both of you, very soon.